Welcome to the Birth Squad podcast. If you're riding with the squad,
hey fam!
And if you're new,
welcome to the squad. We're your hosts, Dr. Ijama Okwando and Dr. Kanisha Thomas. We're two licensed obstetrician and gynecologists, as well as best friends.
The Birth Squad is a podcast for birthing individuals by two Black female physicians who use stories from real women to educate about pregnancy, birth experiences, reproductive health, and all things in between.
And while we hope that you love learning from our podcast, it is not intended to be a substitute for medical advice, diagnosis, or treatment. So please consult your healthcare provider for your specific care. And to learn more about us and about the podcast, please follow us on Instagram at The Birth Squad. And also check out our website, thebirthsquad.com.
Please keep in mind that some of our episodes may cover topics that could be triggering to some individuals. Listener discretion is advised.
Hello, everyone, and welcome back to the next episode of the Birth Squad podcast. I am so excited today, as usual, to introduce wonderful guests that we have today. We have two anesthesiologists that are actually specially trained in obstetrics, specifically, who are here to talk to us today. We have Dr. Martinez and Dr. Burton. Well, thank you so much for coming and welcome to the Birth Squad.
Thank you for having us.
Yes, so do you mind both telling us about yourself and what was your path to anesthesia, and then specifically OB anesthesia?
Wonderful. I'll go first. So my path to medicine was not the most straightforward path. I did undergrad at UCLA. I'm originally from Los Angeles. And from there, I kind of thought more public health. So I moved to the East Coast and pursued a master's in public health at Johns Hopkins. And it was really there that I had great mentorship, and it put me on the path to academic medicine. So from Baltimore, I applied to medical school. I went to medical school in San Diego at UCSD. And then again, really great mentorship there from a research standpoint, which introduced me to anesthesia, like OB Anesthesiology. And then from there, residency at UCLA for anesthesiology. And I've always had an interest in maternal health. Black women in our community are the stronghold. So from that experience brought up, as well as my experiences at UCSD, that put me on the OB anesthesia.
Hi everyone, my name is Esther Martinez. I'm also from Los Angeles, born in Nicaragua, but I grew up here in Inglewood, California. I always thought I wanted to go into medicine, specifically family medicine, to serve our community and see the whole family spectrum of medicine. However, when I got to medical school, I realized how much I loved working with my hands, working in the acute setting, working in the OR. I found physiology pretty fascinating, and working with patients, it's in such a critical time period of their life point that I thought, I think anesthesia would be the perfect area. Before I got to UCLA, where I did my anesthesia training, I went to UCSD for undergrad. I actually also had a roundabout way to get into medicine, as I took 4 years off in between medical school and undergrad. I had the incredible opportunity to work in Washington, D.C., work in Congress, at the White House during the Affordable Care Act, at the CDC, doing communications work specifically for Spanish-speaking communities. And then after medical school, when I decided to after residency, when I decided to do anesthesia, I decided OB was the perfect field, and where I get to, work with Latino communities specifically, and Black communities where you see so much mortality and morbidity that's plagued our communities. I feel like, being a woman of color, we were in the perfect opportunity to provide more meaningful care to our communities. And so I ended up doing my OB fellowship at Stanford, and now I'm back here in Los Angeles.
Thank you for sharing that. You both mentioned that you are specially trained in OB anesthesia. Can you just share with the listeners, what does that mean, and what role do you play in the team? How do you collaborate with the other members of the obstetric team, whether they're midwives or OBGYNs, to provide care for women in labor?
So from an OB, and that's a great question. From an OB anesthesiology standpoint, the goal when you do a fellowship is to develop the expertise to help manage high risk. So women that are over a certain age, women that have certain medical comorbidities, women who have had back surgeries, women that have significant scoliosis, etc. So our role is really, I think about more of a perioperative medicine role, where we evaluate the patients before labor and delivery. We get a sense of what their goals are, what they want, their birthing plan. We share with them what we can safely offer them, and we have a discussion with them, their OB anesthesiologists, and we get a sense of what's the appropriate plan for the patient. And then on game day, when it's time for baby to come, we have a plan and we're basically ready.
So our patients, a lot of them are most interested to know what exactly are the pain management options during labor, and then what are the pros and cons of each of those methods?
In terms of pain management options during delivery, it will definitely be based out of what your institution offers, what the hospital offers. But the most common type of pain management options, I like to tell the patients. So most common are three types. So it's first is I'll go from the least invasive to the most invasive. So first is what we call the nitrous gas, kind of known as the laughing gas that you may have heard used in the dentist office or during other short procedures. So essentially it's a gas that kind of relaxes you a little bit, gives you, in terms of on the pain scale, I like to tell patients, if your pain is maybe at a level of 6, maybe it'll bring it down to a 5, maybe like a 1-point scale. So it's not the most effective, but for some people who want to try the least invasive option first, it's a great option. The only downside it is when I tell patients they're on and off medication. So as you're breathing it, you're holding the mask in, you get a little bit of relief, maybe during the contractions, and then you take it off, you stop breathing it, and then you don't have to get that benefit anymore. So it's very, you have to do a lot of management with it. Some of the side effects are also nausea. Some people get a little bit discomfort, trying to manage something when they're already dealing with contraction pain. So it's not the most popular option, but it's there for, again, those who want to try something a little bit less invasive. The other option we have is our pain medication that we give through an IV, so that little catheter fits in your vein. One of the most common forms of medication that we use is fentanyl, which is a strong medication, but it provides adequate pain relief during those strong contractions. Depending on facility, sometimes what we do max you out at a certain dose because at high and doses, because the higher in dosage we get, sometimes you get a little bit more sleepy, more tired. But we want to avoid that during your delivery process. We want to make sure your head is in the game, we're getting all together, and we could take care of you as best possible. And then at certain points, it also starts affecting the baby, where baby starts getting sleepy, and we also want to avoid that to avoid any emergency C-section that we might have to do if the baby gets a little bit too sleepy and the heart tones go down. So we max it out at a certain dose, and we're working together with the nurse to ensure we're giving you what's optimal for your pain relief. And the third option would be the most common, which is epidural medication. So the epidural is essentially medication that goes through your back, and we're giving you medication the goal is to get you a little bit numb from your belly down. So while you still may feel the contraction and the pressure of the contraction, you're getting adequate pain relief, and that we're numbing down the pain. One of the benefits of that epidural is that you still have mobility. It's not sedating you at all, and you're just feeling very relaxed, able to relax you during your birthing process to the point where you just save all that energy for when it's time to push. And then those would be the top 3 most optimal options for pain control. However, we always tell patients, at the end of the day, sometimes it's your baby calling the shots or your body calling the shots. So, pregnancy could change from one second to the next, and sometimes we do have to do general anesthesia. That means putting you to sleep to get into baby through a C-section to make sure you and baby get through this procedure safely. And although it's a very rare likelihood, if you're overall healthy, that you will go through a C-section, it's always in the back of our minds because as anesthesiologists, although we may have talked about plan A and B, we're always thinking about plan C, plan D, and any emergency scenario where we have to be on top of our game and make sure we get you and baby through this procedure safely.
Thank you. That's a great summary. Yeah, appreciate that.
I was wondering if you could briefly talk about, there are some people, for whatever reason, because of complications of their pregnancy, may not be able to qualify for an epidural. In addition to the nitrous oxide, is there any other alternatives for them?
That's a very great question. And I think the answer sort of depends on the institution. I must say that the opinions that we're giving are opinions of our own. There's a lot of different institutional practices. Some academic centers, they do have ready fentanyl, which is a very short-acting opioid or narcotic medication. It may not be widely used at other institutions, but that's another option. In addition, as Dr. Martinez mentioned, IV medication. Some medication like fentanyl might be something that we can use. IM morphine is another option. It's longer acting than fentanyl. But short of neurological anesthesia, we really have our IV medications that could help the laboring process. And in that way, that's probably the best option.
Yeah, thank you for adding that. That's an important clarification. You mentioned, Dr. Martinez, you mentioned that when you get an epidural, you have some mobility. So I was hoping you can talk about the process of getting an epidural and what people can expect, and then kind of touch on the question that we get all the time is, can I have a walking epidural? I'm like, what does that mean? Can I turn the epidural up? Can I turn the epidural down? So if you could just kind of mention that, either of you actually, like, what does it look like to get an epidural, and what are addressing some of these concerns people have about getting an epidural?
So the traditional epidural, great for pain relief. But the downside, so you have to talk about pros. So the downside of an epidural is that you in fact may have motor impairment. You may in fact have sensory impairment. And the combination of those two alone can significantly impair your abilities. So a lot of practices, once that epidural in place, you are now sort of confined to bed. Although you may still be able to move your legs and you may feel like you can walk. From an institutional, from a safety standpoint, you're now considered a fall risk. So again, can't speak for every institution, but at a lot of institutions, once a traditional epidural is placed, you will be in the bed. You'll have a fully place afterwards because now that you're in the bed, you will not be getting up to walk to the bathroom. Now, a walking epidural is this idea of having an epidural in place and still maintaining that ability to walk. There is some data to show that maintaining the ability to walk improves and helps the delivery process. With that being said, placement of a walking epidural is very similar to placement of a traditional epidural. So we clean the back, we numb the back up, we prepare the back for the procedure, and we place that catheter that Dr. Martinez was referring to. So then that catheter stays in place. The difference is the type of medication the anesthesiologist can use. Okay. There are different options. You can use primarily local anesthetics. You can use primarily opioids. And the idea of the concentration and the type of medications will differ when you are placing and offering a walking epidural compared to placement of a traditional epidural. Whenever a walking, I will say to most institutions, when a walking epidural is placed, there needs to be a 1-to-1 nursing ratio. So one nurse for that patient, because anytime that patient now wants to walk, there needs to be a motor assessment to make sure you still have the ability to walk. If there is no motor assessment and you do not have the ability to walk, that is now a fall risk. So a motor assessment by the nurse, and the nurse needs to also be with you as you walk around. because again, that's significant fall risk. I should also say that walking epidurals are amazing, but oftentimes there is inadequate pain relief. Why? Because the concentrations and the formulations of the medications you use are very different than your standard or traditional epidural. And I would say, in my experience, there's roughly a 100% conversion rate where a walking epidural is offered. And at some point during that birthing process, as those contractions become more frequent, women prefer the standard or traditional epidural. But it is something that many places can offer. But again, there's a lot of institutional differences in terms of how comfortable they are offering a walking epidural because of the protocols, the nursing ratio, etc.
Thank you for explaining that. That really helps clarify some things for me too. So you all mentioned an epidural, but we also heard of a spinal. So what are the difference between spinal anesthetic and an epidural? How do they individually affect pain relief? When is one used? When is the other one used? Just so we can all kind of have a better understanding of that.
So in terms of an epidural versus a spinal, so the way I think about it is typically, okay, what are we doing? Are we laboring for vaginal delivery, or are we going to a C-section? So an epidural is great because you're leaving during that procedure, you're leaving a catheter in place, which is a thin and flexible wire, and you are delivering, you're connected to an infusion bag, and that infusion medication is going through that catheter into the epidural space, bathing those nerves and providing effective pain. So there is a catheter left in place. So in theory, you will have pain relief as long as you're receiving that medication, because you get a constant amount of medication per hour. Okay, but with a spinal anesthetic, there's a procedure that's done. That procedure is very similar to replacing an epidural, with one exception. Well, with the couple, but the most important one is you do not have placement of a catheter with spinal anesthesia. So basically, there's just a single dose of medication that is delivered into the space around the spinal cord that provides pain relief for as long as the medication lasts. So what that means is that if the medication lasts 2 hours, you've got pain control for 2 hours. And you can imagine that may not be appropriate for laboring, right? Because we know that the laboring process can be very long, much longer than 2 hours. So you can quickly see how the procedures we offer are tailored to the birthing plan. So typically, spinal anesthesia is more appropriate for a cesarean delivery, more appropriate for an elective cesarean delivery where emergencies are not a concern, because most C-sections can be done in under 2 hours, most time. And then you can imagine that an epidural is going to be more useful, more impactful in the laboring process, because you will need pain control far beyond the 2-hour period. So that's sort of the quick and dirty of the difference between spinal anesthesia and that.
Beautiful. Love that. I asked you guys a question. I'm sure it's like opinion related, right? So go ahead and you can say what your opinion is. But a lot of times people will also ask me, when's the last opportunity I have to get an epidural, right? I'm 10 centimeters. Can I still get an epidural? And then also, if you could answer, how are they safe? You mentioned epidural spinal. Is that safe for the baby? So if you guys could just answer those two questions, I would love to get your opinion.
Yeah, well, I'll say from the get-go, all the medications we use for our patients are safe for mother and for baby. There are at points where the dosing of the medication maybe gets you a little bit too sleepy, so maybe it gets baby a little bit too sleepy. And that's how, when we talked about earlier, the heart sounds of the baby start to go down. And so we try to prevent that by having your anesthesiologist is in you in the room as we're getting the medication. And we're monitoring the first few minutes after the procedure to make sure you and baby tolerated the procedure well. And so, sorry, what was the question?
When's the last time I can get an epidural?
So I usually like to tell my patients that they're essentially, you could get the epidural at any point. But what I like to remind my patients is that the procedure is still a procedure, and where we had to get you into a seated position, bent over, so we could stretch out your back. The way in which you stretch out your back is so we can see your bones in the back. And so the way we do the procedure is we numb your skin, and then we put a little bit with a little injection medication. We numb your skin, and then you're just going to feel pressure at that point. We're going to use a different needle to get to that point where we're going to infuse the catheter with the medication that's going to go around your nerves. So that procedure requires you to be very still. It's a very, intricate portion of your back. Your nerves are back there. We don't want to injure anything. So we want you to be as still as possible during that procedure. So some patients will come in and say, well, I have a lot of anxiety. I have no pain tolerance, so I want it as early as possible. That's completely fine. We'll talk to you and your obstetric team to ensure it's a safe alternative, but we will work with you around it. However, this one of the patients say, well, I want to see maybe if I could try natural work or see if I could extend or delay my epidural as much as possible. And, at the same time, same as our other patient, we'll still work with you through it. But the only thing we want to remind patients is that for the procedure, you have to be still as possible. So we don't want you to aspirate where you're at 9 out of 10 pain and you're like, driving over your bed, moving around. It just makes the procedure a lot more complicated for us. And of course, we want to make this procedure as safe as possible. So we could do it as safe as we can. However, in order for it to be safest for a young baby, we like you to be in a seated position as still as you can. So I'd like to tell patients don't wait too long. And at the same time, remember, we sometimes have maybe 10 patients laboring on the floor, and it would be an emergency C-section called where the anesthesiologist is the only one on the floor and gets pulled away. So if you ask for that epidural, we are at 8 out of 9, 10, and we have to wait for that C-section that takes an hour long. You'll unfortunately be waiting there for that epidural for an hour. And we don't want you to be suffering through all that time period. So whatever point you feel like, okay, my contractions are getting a little bit stronger, 6 out of 10, 7 out of 10 pain, let us know as soon as possible, because sometimes we do try to get the epidural placed in between your contractions. We're skilled in that way. But again, it's still, sometimes it takes us the procedure less than 5 minutes, sometimes it takes us 20 minutes. Just never know what we'll encounter once we're in order for the procedure to be placed as the epidural to be placed as safely as possible. We need both cooperation on your end, and that entails you being able to sit in a seated position where we can do the procedure safely.
And then also to piggyback off of Dr. Martinez, I basically say something very similar. I tell my patients, whenever you want the epidural, we can place it. However, the extremes are going to be challenging. So if you're 10 centimeters, crowning, feeling like you have that urge push, it's going to be very, very challenging for you to get in an optimal position for us to place it. Even if how sometimes you can place the thing, you can also place the rattle. So that's one extreme. Another extreme is we have a fair number of women that come in for an induction, right? Induction of labor. So in that case, some women are very afraid, rightfully so, of experiencing any pain. So I've had it before where women want the epidural before the induction process starts. And while we can't offer it, we know that our epidural is working when we treat the pain that you're having. I'll say this, that epidurals work very well, I would say 80 to maybe 90% of the time. There is that crossing sign that despite our best efforts, despite what we would consider beautiful placement, it may not work for me and give us the adequate pain control that we want. So with that being said, it is helpful when I know for us it's helpful when you're in pain, but it's helpful when we have some contraction, some related pain, so that when the epidural is placed and you no longer have that pain after we start those medications, we are pretty confident that the epidural works well. There are other ways to determine and have a sense of how well the placement is, but that is one way to also determine. So in short, I just tell my patients, barring the extreme, any time in between, you can ask or have you come high place.
Speaking of timing of an epidural placement, at different hospitals that I've worked at, there's been different things that I've heard about the recommendations for avoiding eating, right? How many hours before an epidural is placed can people still eat? Are people allowed to eat while they have after they have an epidural placed? Can you even just explain why this whole eating thing is even up for discussion in relation to epidurals? And then what type of risk may it pose to women if they're like, maybe having a big meal right before receiving this form of pain relief?
That's a great question. And this is kind of gets that, what you call NPO, nothing by mouth, NPO status in medicine in general. But the idea behind being NPO is that there are some studies to show, your early studies to show an increase in maternal death due to aspiration. I'm about full, so let me kind of break that down a bit. So, aspiration is when we vomit and the contents of that vomit goes into our lungs. The content is acidic, so it causes damage to the lungs. So there are early studies to show that if that were to happen, it increases the risk of maternal death. So this idea of nothing by mouth of pregnancy was born out of those studies. In addition, there are normal physiological changes in pregnancy. One of those is that during the laboring process, gastric emptying may be impaired. What that means is that during the labor process, you can imagine there may be some nausea because of the medications, anxiety, and the pain. There may be some vomiting. You may be receiving medications that increase the risk of nausea but are intended for pain. And if you then have a full stomach of Chick-fil-A or McDonald's, you can imagine how that can be a source of complications. So in short, this idea of nothing by mouth was born out of the studies to show that you had a full stomach during this laboring process where there is a lot happening, your risk of vomiting is increased. Your risk of that vomit going into your lungs is also increased. So the practice and variation, practice varies across hospitals. Where I practice, we typically avoid heavy meals once the epidural is placed. Okay. But ice shifts and water are okay. And again, the idea and thought is that we really want to do our best to decrease the risk of aspiration.
Thank you so much for that. Really, really important point for a lot of people who might not understand that. So we really appreciate you sharing that with us. I want to kind of shift gears a little bit and talk about women who might be hesitant about getting pain medication during labor. Maybe they've heard, oh, someone got an epidural and they have back pain like forever afterwards, or they hear about like a spinal epidural or spinal headache, excuse me. Are there any things that you've seen, like alternative or complementary therapies that you've seen people use in your practice to manage pain, that you've seen them use successfully? And then additionally, what do you tell people who have those concerns about the back pain and the headache? What is your counseling for those patients?
Always tell patients that, like you mentioned earlier, you're coming with your birth plan for some patients, and you want to adhere to it as much as possible up to the point where it's safe for you and baby. So some people, they've already tried things before they're leaving, breathing process. So whether it be like candles, they found the doula comes and helps them. A lot of doulas and midwives come into the laboring floor with them. They could do alternative forms of therapy, like massages, other things like
Massages, candles, presence of a doula. There are a few things that we've seen that may help women. But by nature, we're anesthesiologists and we work with our hands. So neuroaxial anesthesia is always what we have to offer the patients. And I find that patients that want to avoid any significant intervention with respect to anesthesiology normally have a birth plan, oftentimes have a doula. They've been working with that doula somewhere since like maybe the second trimester. They also have a fair amount of family support. Partners in there running their bathroom massages, relaxing music, candles. So there is an entire experience that I've seen work very well for patients that are incredibly motivated. And I say motivated because working through those contractions is quite the task. So if patients are motivated, I've seen I've seen those approaches work pretty well.
And let's talk about what do you do when someone comes with those concerns because they heard a friend had back pain forever after their epidural, or a friend had a spinal headache. Can you explain a spinal headache and then kind of talk about your counseling around that?
Oh, absolutely. So I think now we're getting into, we have a sense of pros of epidural because we know that it helps pain relief. But like, what are some of the causes? What are the things I need to be concerned about? And some of the causes is really your informed consent process, which is super important. This is an important sign to have a discussion with the patient, get a sense of what their concerns are, and do your best to provide them the information. And ultimately, it's their decision, your choice to make a decision. But in terms of the complications from an epidural, so anytime you use a needle, there is obviously a risk of discomfort. There is a risk of infection. That risk, based on some data, is about 1 in 60 to 70,000, so fairly infrequent. There's a risk of nerve injury, not necessarily spinal cord injury because we place the epidural pretty low. I don't want to get into the weeds here, but I'll say the spinal cord ends at about L1, L2 in most people. We place the epidural below that. So we're not necessarily touching the spinal cord, but there still are nerves in that area. So I'll say the risk of significant nerve damage is about 1 in 40,000. So overall, again, we see pretty low in terms of those complications. But if you bring up the headache, and the headache roughly is about 1%, so I would say of the complications, that headache is, we call spinal headache. A headache is probably the most common and the most we make out sit right out. It is not life-threatening. We have conservative measures, and then we have interventions that we can offer to help decrease the pain associated with the headache, and essentially take the headache away from you, for lack of better words. So what is a spinal headache? So it's a very characteristic headache. It's not like your typical migraine. It is a headache that is worse when you sit up and you walk around. So when you find that you're engaging with the baby, but you're having this excruciating headache that just won't go away, but when you're laying down, it's all of a sudden magically gone, that is a headache that may be associated with our anesthesia procedure. Again, not life-threatening, but something you need to know. If you do have that headache, oftentimes it will appear within 3 days of your neuraxial anesthesia, your epidural placement. If you elect to not have what's called an epidural blood patch, which is a procedure to help alleviate a headache. If you elect to not have that, I would say in the vast majority of patients, a headache will resolve within a couple weeks. But there still are some patients where a headache does not resolve, and the epidural blood patch is a good option. So the epidural blood patch is another procedure we do similar to placement of an epidural, where we take some of your blood, we put it into that space, and it basically helps to patch up that area and decrease those symptoms. So basically, I think having an informed discussion with the patient, in the sense of what their concerns are, giving them the honest, true numbers in terms of what they are most likely to experience in terms of complications. I think that holds very well. And I think people get a lot out of clear and honest transparency. And for me, that has worked pretty well in my practice, and that's something that I make sure I do with each and every patient.
The question about permanent back pain or long-term back pain, that's actually a question I get a lot from my Latino patients. And even from my mom herself, they're like, oh, I heard this. My mom has never had an epidural, having had both my sister and I in Nicaragua. And so I like to remind patients, when we're doing the epidural, we numb your skin first with a little injection. With just any needle going into your body, when you get a flu shot, when you get injections elsewhere, you're going to be sore in your arm for a week or so. And so similarly, we're going through your skin and muscle in the back. And so we anticipate that area where we did the procedure to maybe just have a little bit of dullness of pain, which isn't uncommon. I would also like to remind patients that, when you're going through the birthing process, your baby's head is kind of lodged into your back where your nerves going down to your legs are and your back are. And so, in some women, birth could be as quick as 3 pushes and baby is out. But in other women, whether they have a smaller pelvis or any other variants in anatomy, sometimes baby's head is lodged there for a few hours. And if you have an epidural, you might be numbed up to where you're not sensing that kind of like nerve irritation that your baby's head is giving you. It might come appear maybe a day after when the anesthetic medication from the epidural is completely out of your system. You're like, oh, now I have this numbness in my leg that wasn't there before, and that could be from the irritation of the baby's head that was like pressing on your nerves close to the birthing canal during that long period. And so we remind patients, it isn't. We remind patients that having the baby there for a long period of time could cause a little bit of nerve irritation, but it's nothing that we don't have therapies for. We always like to advocate for physical therapy. If at any point you have any of these concerns while you're in the hospital, like I mentioned earlier, definitely let your OB and anesthesiologist know, as we don't want to send you home with any of these defects. We want to make sure you're walking outside of that epidural, able to take care of your baby. And so any form of headache that could maybe appear after the epidural, any nerve irritation, like, oh, I'm getting some numbness in my leg or my back is a little bit achy, definitely let us know. That way we could triage everything before you head home, because we want you to make sure you're feeling good and ready to take care of your baby once you get home.
Okay, so I wanted to pivot a little bit now. I'm not sure if the two of you knew, but I actually did an OB anesthesia rotation while I was in my residency. And I already thought this, but really doing that experience made me realize even more so that anesthesiologists are like the silent superheroes of the whole like OB experience and also for our surgeries. There is a very specific role that anesthesiologists get to have, um, especially during a C-section and especially during like emergencies. So can you just elaborate a little bit from your experience? What role do the anesthesiologists play to ensure like the well-being of both, mom and baby, especially during these like emergency situations?
That's a great question. So the role that we play. So say we come into the room, you want an epidural, we place the epidural, you've got great pain control. You have now what's called labor analgesia. So you have the pain control. God forbid, your obstetrician gynecologist determines and declares that, hey, you need to have an emergency C-section. We now have to transition from labor analgesia, labor pain relief, to what we call surgical anesthesia, right? Because this is now a surgery you're going to have. So I think of our goal at that moment twofold. So to make sure you have enough pain medication on board to be able to tolerate surgery, and then also to keep you stable. So what that means is keeping all of your vital signs within their baseline normal range. So your blood pressure, your heart rate, your oxygen status, etc. So our goal is to ensure that the obstetrician gynecologist to operate, you can tolerate the operation because you have good pain control, and that your vital signs are stable throughout the entire procedure. That's one emergent situation where anesthesiologists and OB anesthesiologists are incredibly crucial. There are a few others, like postpartum hemorrhage, retain products, and a few others. I won't go into the weeds too much, but I would say by far and large, us being present for an emergency C-section is number one. You definitely want anesthesiologists in the room at that time.
I like to remind patients also, just like you go to your primary care doctor to manage your hypertension, your diabetes, your asthma, but you're in the operating room, we're your primary care provider for that surgery. So we're managing your diabetes, your asthma, patients who are developing preeclampsia during delivery or during the laboring process. We're talking closely to the surgeons. They're the ones who are in the weeds of the surgery. So if they're seeing a lot of bleeding that's starting to start up, we're already thinking, okay, we need to get blood in the room. We need to get access to ensure we can get that blood into you safely during the process. And we're also ensuring that our medications aren't interacting with baby. We have the baby doctors in the room as well. We're talking with them, ensuring baby is getting through the procedure fine. So, in addition to managing your pain, we're having to manage all the comorbidities associated throughout the labor process. And so, although we're very busy, we're right there. Our head is literally in the game. We're right next to you as a patient. So, our job is to not only reassure you, but also reassure our surgeon that things are stable on the other front. They're so focused on the surgery and baby that it's only left to us to manage everything else.
And in addition, I would say it's wonderful when we get to be your family medicine or primary care provider, but in an unfortunate situation when we have to be your ICU provider because there's an unfortunate cardiac arrest, blood clot in the lungs, a blood clot in the heart, any significant complication that causes your heart to stop, we are now your ICU provider, and we do our best to manage and run that situation and make sure that the outcome is the best outcome for you and critical.
Yes,
Such a great point.
yeah.
Such a great point. Yeah. I think it resonates so much with us because when you said that, I'm literally going through all the emergencies I've had where in my head where I'm like so reassured when the anesthesiologist walks through the door, or you're like, call the anesthesiologist. Even in our training, when we talk about a hemorrhage, there's like an algorithm where if you're getting to a certain level of medication, the instruction is to notify the anesthesiologist of what's going on. So I think people just don't realize how much we work hand in hand with you, and how much we rely on each other, and how much communication happens between us. I just wanted to say that piece, but go ahead, Ijama. I interrupted you. Yeah.
The other thing I wanted to say is like, in addition to all of that medical management, there's also such of like the human aspect of it, right? Because the surgeon has that big blue drape in between them and the patient. So there's not much communication. If there is, it's just like this, faceless voice over the curtain. But you two, as anesthesiologists, are actually like right next to the patient, can really connect. You're often the ones giving that reassurance. You're sometimes the only eyes they actually get to see. And then, when I see these patients postpartum, they're asking about, oh, who's that anesthesiologist? I don't remember their name, but they really helped me through that moment. So I just want to just acknowledge how much of an important role you all play in those situations.
That's wonderful. I'm so happy to hear that they're asking about anesthesiologists because the situations are often very critical, and we are managing the critical nature of the situation and managing the expectations, the emotions, the fears, holding hands at the same time, making sure the partner is okay. There's a lot that's happening, and we don't always get a sense of how the patient feels about the experience. So it's wonderful to know that oftentimes you're asked, who is the anesthesiologist?
I will say, don't get me wrong though. I feel like it's also a good day sometimes when you don't know the anesthesiologist. What does that means? You had a very safe day for everything went great. You and baby did fine. So it's fine starting to get to know each other a little bit better. It's like, okay, but don't worry, we're still in the game with you. And I definitely like to take advantage of this opportunity to also thank our nurses who are played just as big role during the whole cesarean process and laboring process. I know when things have gotten heated, emergencies happen in the OR, there are extra hands, as anesthesiology, we have to take care of your airway in an emergency setting, intubate you, place larger IVs, ensure blood is going into you as fast as possible. And those nurses are really our right hands because we don't have 10 hands. So this really is the team player kind of game, and I appreciate our surgeons just as much as our nurses.
Well, thank you so much for everything you had to share so far. Is there anything else that you want to share with the Birth Squad?
Thank you so much for having us. We really appreciate it. The questions were very comprehensive, and I think we touched on some very important points. So I think at the moment, the little questions are good places to start. But if you all have any questions, you can contact the Birth Squad, and we are happy to engage in more discussions.
Thank you guys again for having us. And again, just want to remind everybody, we know this is always a critical time period in a woman's life. We want to respect your choices, make sure this is just as a joyous, monumentous time for you as it is, relaxing and stressful. So want to make sure that always have those open conversations with your obstetrician and your anesthesiologist. At the end of the day, we just want to see you and your babies going home happy and healthy. So we're here for you 24/7 and reach out to us if you guys have any questions.
Well, thank you so much. You have both been amazing, and I know our listeners will learn so much from you all and will feel so much empowered and informed to have the birth experiences that they want and deserve. So thank you.
Thank you.
Thank you.
That's the wrap of this episode of The Birth Squad.
Thank you so much for joining us this week. We are going to continue sharing stories from more badass birth warriors, because at the end of the day, you are the experts of your experience, and we want to highlight you and your bold, brave, and beautiful journey to motherhood.
And we want to hear from you. Tell us about what topics you'd like to hear more about. Hit us up on Instagram at The Birth Squad, and check out our website, thebirthsquad.com.
Most importantly, be sure to share this episode with your squad.
Until next time, I'm Dr. Ijama Ogwandu.
And I'm Dr. Kamisha Thomas.
Peace, love, and solidarity from the Birth Squad.